Before we start, I thought I'll make one slide to say that the Mitra clip, what is the current landscape? So at least what you should know is that the Mitra clip is the currently only approved therapy, the primary MR, people who are at high risk or prohibitive risk, and what is there in the near future. So COAP trial will be presented at the TCT. Neocord and Harpoon TA approaches are ongoing trials. Carillon is a coronary sinus trial that is starting the pivotal trial. Already sites are recognized, and they are going to have reduced FMR presented at the ESC. Direct annuloplasty, cardioband and millipede are very important two rings that you are going to hear about and ongoing. And early feasibility trials, so I put these 5 valves, Tendyne, Cardiac Q, Tierra, 12, Kazan, and M3, you may know. And Navigate, you may know, but a little bit. And Pivotal is the Interpret and Tendyne. So this is just the list. What are the things that are there and all fuzzy? There's several of them, as you can see here. And then there's several of mitral valves that are there. So I want to talk to you about one valve that we are involved with, which is called Navigate, which was designed by Dr. Navia in Cleveland Clinic, and company spun, and I and him helped together. The advantage of this valve is equine pericardium, and it goes up to 52 millimeters, 52 millimeters. So remember that, 29 is largest valve. So the first one was done, and most of them are done in the mitral with a transatrial approach. So this is the first patient. As you can see, it is 3 years ago. Patient is still doing well, and this was done transatrially. And the way it anchors is that it has just hooks that anchors the anterior leaflet. So it does not cause any LVOT obstruction, and that is the advantage. However, because of the size, we decided that we'll use this in the tricuspid valve, because it is a very large valve, and we can deploy it in tricuspid valve. This is the 3D printing and tricuspid valve. This is our first patient ever. And as you can see, we are doing transatrially. And the first patient was successful. Subsequently, I should play this. This is the way the valve is deployed. So we have, as you will see, some injections. There is a pacemaker wire. It's not a contraindication. We have put a wire in the right coronary artery just to size the size of the aortic valve. You can see what is the size of the aortic valve and what is the size of this thing. It is big. We are releasing it very, very gently, and you will see that we will inject dye because we have a catheter there, and we will check that we are in the roughly the right spot. And here we are going to slowly deploy the valve. We are checking it with the TEE. Valve deployment is slow, and it has those hooks that you see. And these hooks are going to engage into the tricuspid valve. It opens fairly the last piece is going to open rapidly. And when it opens, it will cover the entire tricuspid valve and tricuspid annulus. So it is that big compared to the aortic valve that you see. And if you look at this, so this is the picture of the TR before, torrential TR, subcostal view, tricuspid leaflet, and the patient has no tricuspid regurgitation afterwards. And now we have done 14 patients, and we are going to do 2 more patients next week, week after next, at Northwestern. So there are several different places we have done these cases, including Columbia, Cleveland Clinic, and in Europe. If you look at this one, this is the only one, and there is one other one. This is the first one ever that we did it transjugular. This is a 40 French sheath, and we did it completely closed. And you can see that the sheath is large, but it is venous, and we did it totally percutaneously. And patient did have a ring, partial ring, and I'll just run it fast so that we can go to the other important one. And finally, this patient also did amazingly well, and he's doing well. All these patients are alive and doing well at this point in time. So this is the one that we have not disclosed so far. So this is something new that at Cleveland Clinic we are developing. Again, Jose, myself, and Marwan is here too. Very simple concept. So we want to have, the idea is that when the posterior leaflet is restricted, it is moved back. So can we put something behind the posterior leaflet to just come close to the anterior leaflet? So it can meet the anterior leaflet. So this is one of the designs, the early design, which is, of course, as you can see, is one of like an implanted device. But the idea is that we would put, like, come from the aorta, put a small wire in the annulus, dilate a little bit if you have to, and we would go on the other side and deploy the device right there, which would allow the posterior leaflet to be pushed anteriorly. So where we want, wherever there is a posterior leaflet restriction. So there are several surgical similes where there are rings that are developed that would push the leaflet while they put the rings. And we tried this in some of the explanted hearts, and we could accomplish that in the humans. And so now we have done several animals, and even chronic animals, with both the arterial retrograde, as well as doing it from the transapical axis. And as you can see, it heals well. It does push the posterior leaflet up because we have designed it a little bit differently. So this device is a little stronger than a regular implanted device. It does have a little bulge so that it pushes the posterior leaflet up. And you can put it in either P3, P2, wherever there is more leak, just to have. And the idea is that it will not restrict any future options. You can still do whatever you need to do to the mitral valve. You can still put a clip. You can still put a new valve. You can still put a ring. And all these things are still possible, is the idea. And of course, it can be done with an 8 French sheath from the aorta. I know that this is a very congested road. Traffic is moving slowly in the mitral space. You know, there's so many different things happening at the same time. And everybody is looking for some alternative road and maybe some very skilled drivers. So this is where the field is moving, and that's what I wanted to share. Thank you.
Say, because you go,
Ask one question. Yeah.
We can discuss some questions. We saw that one of your patients has a pacemaker. So what do you do with the pacemaker? You push it? You don't care?
We don't care, it's not true, we care, but the idea is that the pacemaker stays outside. So the pacemaker is not affected by this valve. We have tried it first in the animals, then in the patient, and the pacemaker just goes to the side because you know, it's outside the valve.
There's no change in impedance.
There's no change in impedance. We check the pacemaker again, and if people are completely dependent on the pacemaker, that's why the coronary wire is there. So I put the coronary wire and also pace them in case it's necessary, and then we'll put another pacemaker through the valve. That was the idea, but we didn't have to do that.
Now I have to ask, with your new device, why not transeptal?
So correct. So we did a transeptal too. So we did transaortic, transeptal, and transapical. I'm sorry, I didn't mention that. Okay. So we, of course, transeptal.
Okay. And is that, do you envision that as being the long-term solution?
I found retrograde, means aortic, much easier to do because when the valve went to puncture in the annulus so that you come out in the ventricle is harder. But if you come behind the valve, it's 101 because you just like mitral line or anything like that. Yeah. So you come just behind. Yeah. It is much, much easier because that space is very well defined and you puncture and there's nowhere to go. It just comes out in the atrium.
And I presume there's some RF energy or something
exactly.
you use to
So we use Bowie,
it.
but RF energy, we work with typical RF energy people. Yes, Jason.
I just have to ask, because based on our experience with mitral paravalvular leak, we know that, you know, when you put these amplats or like devices around a valve, if the leaflet touches the device, you know, you get erosion. Like you can get a hole in the leaflet. So, you know, you're putting a big kind of mesh amplats under the posterior leaflet. Do you have any concern that it's going to, you know, erode
So that's
the
why
leaflet?
we did this 90 days experiments, and we did not find so far anything. we are doing certain treatments and certain things to the device so that it is not like how the erosion would
Make it smoother.
make it smoother or make it heal faster so that it forms a fibrous tissue on it and becomes smoother. So yes, this is an important concern, and the clot is a concern, but again, in paravalvular space, at least the clot doesn't happen.
I mean, I think it's a concept of many different things you could do.
Exactly.
Not just a stent. You could do a balloon or a polymer-filled
Correct.
spacer or whatever you want to put in there.
So we first put the balloons in the transplanted hearts. So you're right. And then we can increase the size of the balloon, increase the size of the device, depending on how much restriction you are getting. So this is just an initial concept, but a new one. So that's why we want to share. Thank you.